This is how you cross over from Israel to Gaza, and right now we're in no man's land. Prime Minister, do you now regret when once asked what your favourite joke was, you replied, Nick Clegg? And Deputy Prime Minister, what do you think of that?
Mr. Trump, why should you be president? What makes you fit for the role? Is it just one big ego trip?
Thank you very much.
People aren't sure they can trust what you say. You say things and then it turns out that they're not quite what you said.
And if we deliver what we say we're going to deliver.
My name's Andy Bell, and I've been a journalist for over 30 years. In this podcast series, How Did We Get Here?, I try to provide context and background to a big story in the news by talking to someone with real expertise. This week, vaccination. Never has this been more important to us. Never have we had so many questions. I've been talking to Professor Stephen Evans from the London School of Hygiene and Tropical Medicine. He has 25 years' experience working on the safety of medicines and vaccines. He tells me how Britain got ahead of the rest of Europe on producing vaccines, why politicians should not make pronouncements on scientific matters they don't understand, and most importantly, why the vaccines being rolled out are safe. First of all, thanks very much for taking part in this edition of How Did We Get Here? For the layman, give us an idea just of the principle of the way that vaccination works.
Well, the key thing about vaccines is that they're not like drugs. Drugs work directly on your body. And so if you take an aspirin, then it goes into your bloodstream and then goes all the way around your body, and when you stop taking an aspirin, the effect of aspirin disappears. Both its good effects and its bad effects disappear within a short time. With a vaccine, it doesn't work in at all the same way. It is intended to help the body provide its own defenses against an incoming organism, particularly a virus. And so the idea of a vaccine is that it trains the body to respond, because our bodies are quite amazing. Our immune system is capable of encountering something like a virus and fighting it off, all being well, successfully, and then remembering that virus, and so being better prepared next time.
So when a vaccination is carried out, is a form of the virus being introduced into the body? Is that what's going on?
Sometimes it is the whole of the virus. Sometimes they inactivate the virus so that it can't replicate, can't multiply itself. But particularly with the newer techniques, they insert just a little bit of the virus. And most people have started to understand that there's this thing called a spike protein, which is how the virus attaches itself to your cells in your body. And by just simply having a little bit of the characteristics of that spike protein, then that is enough for your body to be able to recognize it and fight off the coronavirus.
Talking of how long things take, at the beginning of this pandemic, there was a lot of discussion of the timelines of how long it would take to develop a vaccine. And people I seem to remember, were talking about years. How come we've been able to do it so quickly?
The major thing is money. We've put very large amounts of money into it. The other thing is that we have been developing techniques whereby we're able to use things like this little bit of a virus to put into an existing vaccine. And so that technology had been developed for other diseases. And so we were already ahead of the game. And I think in future, we're going to be able to develop vaccines more quickly as a result of that. Efforts have been made to develop vaccines against Ebola. They didn't have the same investment, but quite a number of the methods for developing that were already there.
And why had you been developing those technologies? Was that in response to things like Ebola?
Yes, Ebola, SARS, MERS, and then there are a number of diseases for which we've been trying to get vaccines for a long time and haven't succeeded. The two highest profile are HIV and malaria. And we haven't managed to get vaccines that are at all effective for those. And there are a number of other diseases. Dengue fever is another disease for which we do have a vaccine, but it has a whole lot of disadvantages.
Do you think the work that has been done on developing this vaccine or these vaccines could help with things like developing a vaccine for HIV and malaria?
I think so. I can't say that specifically for those it will work, but I think it's definitely possible that in the future we're going to be able to develop vaccines for other diseases based on the experience we've had so far.
Can I jump back to the money? I mean, we obviously invested a lot of money. What that means is governments, I guess, were prepared to put in a lot of money. And that's because unusually, I suppose, this was a pandemic that really looked like it was threatening richer countries. Is it fair enough to say that?
I think that's very fair. Yes. We have found that the pharmaceutical industry in more recent years has withdrawn from providing vaccines because there's often not a lot of money in it, because we're back to the fact that vaccines don't work like drugs. If you've got a drug that is a really effective drug, you've got to keep taking it. But the great thing about vaccines is, on the whole, you give them once or maybe 2 doses, and you get years, if not a lifetime, of protection. And so there isn't as much money from the pharmaceutical company for making vaccines of that kind. They do make childhood vaccines because babies continue to be born, and there's a bit of money to be made there, but not a lot.
But we're told that, for instance, AstraZeneca are producing this and selling it at cost. In other words, they are simply covering their costs. Is that your understanding?
Oh, absolutely. And this was a vital part of the agreement with Oxford University, because Oxford University had done the initial development work and had got the vaccine to a point where they could produce it, but they could only produce it in fairly small numbers. So they could produce enough vaccine to run the early trials, but there was no hope of them having the manufacturing ability to do it at scale. And so one of the things that we all realized who were working in this field and part of the Coalition for Epidemic Preparedness Innovations was that there is a strong commitment to providing vaccines for poorer countries. And so Oxford University, in a sense, I wasn't party to the negotiations, but I think they said to AstraZeneca, we want you to do that. And so as far as I know, AstraZeneca are the only company who are providing vaccines at cost. And so as far as I know, but I'm not buying them individually, they're by far the cheapest vaccine.
Okay. Now, when we talk about vaccines, and I think this may be partly allied to the fact that we have produced them quickly in this case, people are concerned about the safety. What can you say to people to reassure them about the safety of the vaccines that people will be getting in the UK for a start?
Well, the first thing is to understand that the process of developing the vaccine, you can't just do it on money. You've got to do the tests in the lab. You do tests on animals. And we were able to do a lot of these very rapidly because of the money. But the other thing that was done was that some things were done in parallel, done at the same time, that would normally be done in a much more spread out way. You would do them one after the other. The safety is dependent on how many people you put in the trial. And so putting in tens of thousands, 10 to 30 or 40,000, is probably as big a trial as we've seen. We would have had a shortcut to the vaccine if we'd only studied 1,000 people in the trials. But that we didn't do. We studied tens of thousands. So safety was not shortcut in any way in any of the trials on these vaccines.
Except that, I mean, I certainly accept what you say, but clearly there are some people in Europe, I mean, the German health authorities, the French health authorities have said there's not enough was done in terms of the over 65s, and they are not recommending AstraZeneca be used in the over 65s. You know, they have a point, don't they?
There are two things to that. The first is that the amount of evidence on efficacy, as I said earlier, is dependent on the number of cases. And it turned out that it was slightly unfortunate for the AstraZeneca trial that at the point where they started to recruit over 70-year-olds like me last June, there wasn't a lot of disease about. So you couldn't demonstrate that it was reducing the clinical efficacy. It was just that you didn't have enough cases. You couldn't demonstrate it. It wasn't that it showed it was not effective. It was just that there was some uncertainty around it. The other thing that needs to be borne in mind is that deciding who you're going to give vaccines to is a matter of prioritization. And I think it's perfectly reasonable for people in Europe to say, if I have got enough AstraZeneca vaccine and enough Pfizer vaccine to vaccinate people, allocate the vaccine that has less evidence of efficacy in older people, I will allocate that to younger people. That's not an irrational decision. But I think it is irrational if you go around saying it's because you think it's ineffective. It's simply that you don't have evidence of its effectiveness.
Okay, so it's more a question of lacking the evidence to say this is definitely working, as opposed to concluding we've decided it's not working.
Exactly. And it's slightly bizarre, in my view, for the Swiss to say that there is insufficient evidence for the vaccine. It's as if they are making comparisons between vaccines. We don't license a new statin on the basis that it's better than other statins. You license it on the basis that it works for what it's intended to do, to reduce cholesterol. And I think the problem is that when politicians, even ones who are medically qualified, who are not active in the field, start making statements about vaccines, you realize that there is more to this than the science. There is politics around it.
Well, I was going to ask, can I just jump in there, because I was going to ask you about President Macron and the President of the European Commission, Ursula von der Leyen, who've kind of implied Britain has taken a bit of a shortcut in its regulatory approvals. What do you think of their comments?
Well, Dr. Fauci said the same, and he ended up apologizing and saying he was wrong. No, I don't think that's true. And I think that it's a terrible insult to the MHRA people, who in many instances I know were working 12, 14, maybe more hours a day, 7 days a week, in order to get that assessment done quickly. And to say that that was done inadequately is really insulting, and I think requires apologies from those who suggest it was inadequate.
You mean
they don't know what they're talking about.
You mean people like the President of the European Commission?
Yes.
I mean, so you clearly think there's been a bit of politics at play here in the way they've responded. And is that dangerous in terms of, convincing people that these vaccines are safe?
I think it's extremely dangerous. I think it's dangerous and irresponsible, because I've repeated on a number of occasions my modification of a quote from John Donne, Dean of St. Paul's in the end of the 16th and beginning of the 17th century. No man is an island entire unto itself. And I said, no country is an island entire unto itself. And it's interesting that John Donne has Europe in the next sentence. But the main point is that we're not in this on our own. Viruses don't respect international borders, as we all know. And unless we have an attitude that says we're part of a global community and we should be working together rather than fighting each other and making claims that we're better than others, it was just as irresponsible to suggest that the UK was better than Europe or better than the US in doing the assessment that it did. It wasn't better. It happened to be able to be quicker for a variety of structural reasons. But it wasn't doing any better. And for some of the vaccines, the Moderna vaccine, we didn't authorize it until after other countries had. So it was a special circumstance.
Yeah, maybe that special circumstance by accident or design was that we were out of the EU. Do you think being out of the EU maybe even accidentally, enabled us to move faster on developing vaccines?
In December 2020, that was true. The point about the EU system is that the workload is shared among the member states. So if we get to a point where there are multiple vaccines all requiring assessment, we will be worse outside the EU than we will be in it, because we won't have the capacity within the agency to carry out assessments of a number of vaccines all simultaneously. We could be overwhelmed in terms of workload, whereas in Europe, they are able to have some assessments done by the Netherlands, some by Sweden, some by Germany, some by France, and so on.
I see. All right, I just want to jump back to some specific safety concerns, because it is something that concerns people. I know that I think I'm summing up fairly to say that you believe that the vaccines are safe. Let's take even just what's been announced very recently, the idea of mixing two different vaccines. What do you think of that?
Well, we know from our studies of other vaccines, HIV and malaria being examples, and also dengue fever and some other less known tropical diseases, that giving the first dose of one vaccine and the second dose of a slightly different vaccine can improve the immune response. You can imagine that just in any kind of sense of training, that just training with exactly the same thing doesn't necessarily give you as good benefit in your training as doing slightly different exercises. And we don't have any evidence that in previous studies in which we have done this, that it's been worse. It hasn't always been better, but in a number of instances it has been better. We don't know that, and that's why the trial announced yesterday is going to look at that.
What about fertility, which is something that is raised by quite a lot of people? They are concerned this could somehow affect fertility, especially among women. What can you say about that?
I think that's extremely unlikely. I have to agree the trials did not generally include pregnant women deliberately, but a large number of women have had the vaccine who are pregnant, and a large number of women have become pregnant after having the vaccine. I don't think there's any evidence on that. There's no theoretical ground. It is simply an anxiety, but we don't yet have the data to be able to say, I know for certain that this does not affect fertility, but there is absolutely no evidence to suggest it will.
If anyone were to come to you and say, you know what, I am just concerned about this vaccine, I'm not convinced about the safety, what would you say to them?
I would say I would have it. I had it even in a trial where I didn't know what would be happening. But now we have very convincing evidence that both the Pfizer and the AstraZeneca vaccine will offer you protection, and particularly protection against severe disease and getting to hospital and dying. Even if you get mild disease having had the vaccine, which you may get, and even if you're capable of transmitting the disease, it will reduce that transmission almost undoubtedly, and it will also protect you from very severe disease in virtually all instances.
Do you think this is something that we're just going to get used to, in the rather like the way that you have a flu jab, that with variations and mutations and variants, that we're going to have to come back to inoculate people again and again?
Well, we knew at the beginning of this that coronaviruses do mutate. They mutate at a higher rate than many other viruses, but not as fast as flu. I think it's certainly possible, in my view, but as I say, I'm not a virologist. I think it's possible we may need a vaccine every 3 years, 4 years, 5 years, that sort of time. I don't think we'll need a vaccine every year. And I think particularly when we've found whether we have vaccine efficacy against newer mutating strains and whether we can rapidly bring those into use, that will enable us to drive the level of the virus down, and then we will get fewer mutations.
What about the rest of the world? It looks like Britain is doing pretty well in terms of vaccinating the population. I'm assuming that we can see other rich countries getting there. How important is it that everybody gets a vaccine, and where do you think we are with that?
There are two issues around that. The first, in my view, is a moral issue. We are not an island. We have responsibility to those who are less fortunate than we. And so I think it's very important that we get vaccines to others. If the EU were making a fuss about our not giving vaccines to lower middle income countries, I think they would be on higher moral ground than they are grumbling about their own problems. But I think the other thing is that it is also in our self-interest in the end, because if we've driven the level of the virus down in the UK, and in, say, Africa, the virus continues unabated, you will get mutations there that our vaccines won't be effective against, and we'll get the disease back, and we'll get it spreading in the UK. There are special reasons. The UK is a major international travel hub, or has been, and if we wish to return to that, then we will be vulnerable to virus being imported from other countries. So it's in our own self-interest to ensure that other countries have also suppressed the level of the virus.
I mean, I think I heard a minister talking about the fact that Britain has got more than 400 million doses on order, which is clearly way more in theory than we should need. Should we simply donate those to poor countries?
I think we should be doing a great deal of that. Part of the reason for having lots of things on order was that you put in the orders at a point where you didn't know where the vaccine would work. We've already seen, and I think that I'm not absolutely sure, but I have orders for the GSK Novartis vaccine. But that has hit problems, and it will be delayed. And so that's part of the reason why we over-ordered, was we were hedging our bets in terms of what was likely to work or not. We simply didn't know. We didn't even know that we'd get a single vaccine that would work. Once we had one vaccine, it became more likely that others would work. So yes, I think that even possibly before we have vaccinated everybody in the UK, if we have driven the level of the virus down a great deal, then I think that it is our moral duty to give vaccines to other countries and ensure that companies like AstraZeneca can deliver them relatively cheaply. Some of the vaccines, like the Pfizer and the Moderna vaccines, are going to be very, very difficult to deliver in lower middle income countries because of their cold chain requirements.
And finally, just again, sum it up for me. It feels like Britain is in a good place with vaccination, and this is going to be the way out of the pandemic for us. Is that the way it looks to you?
Yes, but it won't be an immediate solution. It's very important that individuals who are vaccinated do not change their behavior to expose themselves to being at more risk of getting the virus. This is especially true in the first 2 to 3 weeks. But it's also true after that, because it's entirely possible that somebody can transmit the virus at a very low level when they themselves are protected. So we're not in this as individuals, we're in this as a community. And ensuring that we are able to get the level of the virus down by our joint action is going to be very important. And there is going to be no other way of getting the virus down to a really low level unless we close our borders and lock down totally.
But so it sounds as if you don't feel that just getting vaccinated is going to be the means whereby we can start to ease lockdown, maybe even from March?
Yes, it will start to be that sort of thing. Yes, that will help, but you can't just rely on the vaccine alone.
So you think that lockdown measures will continue for quite some time?
Well, I think measures taking care, the sort of mask wearing and distancing and taking care in the way that we behave will go on being important. We won't be able to return to the sort of behavior we had in mid-2019, in mid-2021, in my view. We will have to be more careful. By mid-2022, then perhaps we will have got the virus such that it's no longer a concern. But if we think that vaccination alone will work, it's a mistake, because even the very best vaccines will not be able to vaccinate everybody in terms of protection. And in the trials, you selected people who you thought the vaccine would work in. There will be some people out in the community in whom the vaccine will not work as well for a variety of reasons. So the protection is not 100% from any vaccine.
So some social distancing measures right through into next year, you feel?
I think there will be a need for caution. There may not be a need for formal lockdown, but I think if people do not realize that they can transmit the virus if it's still around, and they can get the virus from others if it's still around, and if they behave as if it isn't there, then that will be troublesome. We've actually seen a dramatic reduction in flu by this method, and it may well be that the sort of way we behave in the future will take that into account, so that we don't have the winter flu peak that we've had in previous years by our behaving differently.
Still be a bit of a sacrifice for a lot of people to behave differently, though, of course.
We won't have to have the same limitations, but it won't be simple.
Professor Evans, thank you very much for talking to us. Absolutely fascinating stuff. And I think we can say hope, but a little bit of tempered hope about how vaccination is going to get us out of this.
Absolutely. Absolutely. I think that it is definitely hope, but it is hope that must not be accompanied by complacency.
Thank you very much. A good note to end on. Appreciate talking to you.
Cheers.
Professor Stephen Evans from the London School of Hygiene and Tropical Medicine with a hopeful but realistic assessment of what the vaccination programme will deliver. If you have thoughts on this or for another podcast, you can email me at andy.bell@itn.co.uk, and I'm tweeting it at AndyBell5News. And please rate, review and share. Thank you for listening to this edition of How Did We Get Here? There'll be another along soon.